This is the free medicine.
Those two I can't tell.
Good afternoon, everybody. There is a sign-up sheet. If you want to speak on a certain bill, if you will sign in your name and tell us which bill you're concerned about. There's my good vice chair. What?
Well, may I say I love the colors today, Madam Chair, and then you got to drink in the well.
Thank you so much. It's closer to orange than it is to red, please.
Okay.
Move we adjourn.
All those in
Favor say woof.
That's an appropriate attire for one.
That's all right. I have an advanced degree from the Medical College of Georgia. So,
1 degree's accredited.
1 degree is accredited. Thank you very much. If I could find an orange jacket, I would go and buy it tonight. So, just so I could wear it. Okay, we've got sort of a full meeting. Let's move to House Bill 249. Representative Sims, if you'd like to go up and talk about this bill.
We're going to have to go over here. The table. He's trying to get the audiovisual stuff going.
Okay.
Thank you, Madam.
Sims, you're on.
Thank you,
Turn on
Madam
the thing.
Chair, lady, and members of the committee. I'm bringing to you this morning House Bill 249, LC 333958. HB 249 is an educational piece of legislation, and I'd really like to begin by showing you just a very brief video that will set the stage for this bill. You working on it? Okay. I will tell you that it has to do with pertussis, the whooping cough disease that we all thought was probably gone. It is making a comeback, and this video will show you how devastating it can be. Maybe. Sure. Oh, who do I need? That's right. I need help. Everybody. Thank you. Thank you, Madam Chair. Okay. Huh? So we're not going to have it. Okay, we're not going to have it. I'll just have to explain and demonstrate. But the video shows a young mother who is testifying to a group of people about her infant child that died from whooping cough. They had no idea that whooping cough was going to be a problem. The child got whooping cough from a family member and died. So the reason we're bringing this is simply to give information to the parents of the newborn children that there is a risk that they can have whooping cough now. The hospital has been asked to give an informational sheet put in with all the other pieces of information that they give to parents when they leave the hospital. That's it. It does not in any way ask for the hospital to give shots, to give immunization, or anything else, just the information so that they will be aware of what can happen to their infant.
I have a question for our legal counsel. I'm going to let my able-bodied vice chairman take over.
Thank you, Madam Chair. Thank you for the presentation. Any questions from members of the committee? number 27. Who we got over there?
Who's number 5?
That's me. Five.
Representative Byrd.
Yes, thank you very much for this bill. Just the cost for the copies, is that going to be bared by?
No, it will be pretty much irrelevant, but there will be some cost to hospitals, but it will be infinitesimal.
Thank you.
Thank you, Representative Byrd. Representative Wilkinson.
Thank you, Mr. Chairman. Representative Sims, is this not the same thing that the chair and I did 8 years ago with meningococcal meningitis vaccinations, where we provide the information to incoming college students and their parents, and we're not telling them they have to do it, but we're telling them why it would be a good idea and that a vaccination is available?
Absolutely, and that's so important. I think education on things like this is probably one of the most important things that we can do for everybody.
Thank you, Chairman Wilkinson. Representative Dobbs.
Thank you, Mr. Chairman. Sorry about that. Is the Department of Health or is the state providing a document that we will provide to all the hospitals to hand out to them, or is it up to the hospital to create their own document?
They will be given the information to insert, to prepare and insert.
By the Department of Health?
The public health, I believe.
Okay.
I may ask for clarification on that.
Thank you so much.
Oh, the CDC. Yeah.
CDC. Thank you.
Thank you, Representative Dobbs. Any other questions from members of the committee? Representative Stevenson.
It's actually
No?
I believe it's Representative Dempsey.
Representative Dempsey.
Yes, thank you. I believe when infants leave the hospital, they are given a huge amount of material anyway, and so this is just one more thing to leave with them, but for nurses particularly to go over. And hospitals are sharing that burden right now because they do not want to see that child or that parent back with a very, very dangerously ill child. So it's a good precautionary measure. And when it's appropriate, I'd like to make a motion.
Thank you, Representative Dempsey. Representative Kaiser.
I waive, thank you.
Any other questions from members of the committee? Anybody else would like to speak on behalf of the bill? Very good. Thank you so much. Pat Cota. Good afternoon.
I'm Pat Cota. I'm the Executive Director for the Georgia OBGYN Society. I would just like to say that the OBs in the state are very supportive of this legislation. We have had a campaign for over 3 years now to encourage hospitals, birthing hospitals, to provide the information and to actually provide shots to mothers on postpartum for pertussis, whooping cough. Whooping cough is a very preventable disease, but the problem is that infants cannot have their first vaccine for whooping cough pertussis until they are 2 months of age. And then they go through a series of vaccines that is not completed until 6 months of age. So for that first 6 months of life, they are susceptible to this disease. And the only way to prevent them from getting it is to make sure that the people around them that the newborn comes in contact with do not have pertussis and cannot pass that disease to the newborn. So by making sure that the people around them that are immunized, we make sure that they can't pass the disease on to the newborn until they've had their series. We also know that 50% of whooping cough that is passed to newborns comes from immediate family members. So being able to immunize the mother at least would go a long way toward preventing infants from getting pertussis. And this disease can be fatal in newborns. So we support this legislation.
Thank you so much, Ms. Cota. Rick Ward.
Thank you, Mr. Chairman, members of the committee. I'm Rick Ward with the Georgia chapter of the American Academy of Pediatrics, and it wouldn't surprise anybody that we also strongly support this bill. Pertussis has made a little bit of a comeback, unfortunately, in children over the last 3 or 4 years, and it's absolutely devastating to them. In an adult, it can crack a rib. The coughing is so violent, and so you can imagine what it would do to an infant child. So we're very supportive of the bill.
Thank you, Mr. Ward. Representative Dempsey, I'll recognize you at this time.
I'd like to make a motion to pass.
Have a recommendation. Do I hear a second? Any discussion? All in favor signify by saying aye. Aye. Those opposed, like sign. Congratulations, Representative Sims. House Bill 249 passes.
Shots, hoping to slow down the outbreak of whooping cough that's infecting babies.
In more than 50% of the cases, they were exposed to whooping cough through their family members.
This is the one that Sienna liked.
That's what happened in Mariah Bianchi's case. In 2005, she was pregnant with her son Dylan and had a terrible cough.
He was healthy, he was beautiful, he was fine. Except I continued to be really sick.
She told her pediatrician she was worried about infecting her newborn.
When I asked her about whooping cough, she told me it was a disease of the past, and she said that we don't see it anymore.
But that's exactly what Dylan developed, and by the time he was hospitalized, it was too late.
In less than 48 hours, he died. The doctors didn't know what they were treating.
Vaccine advocates say the current California outbreak is happening because most adults don't realize they need a booster shot.
Of the 9 children that have died, all of them are less than 3 months of age. They're too young to be vaccinated. They depended on those around them to be vaccinated so that they would be protected, and they've been let down.
Only 6% of adults are properly vaccinated against whooping cough. So if you're going to be around babies, make especially sure you're up to date with all vaccines. Katie?
Good advice, Dr. Don LaPook. John, thank you.
One S, and I believe you have an explanation sheet that is a graph like this in this one to follow along with Representative Chanel as he goes through it. Everybody got one, or do we need to get the aides to find one for you? Okay, Representative Chanel. Turn his mic on. It's on.
There we go. Thank you, Madam Chair, and members of the committee. I bring you House Bill 214, which is designed to do one thing and one thing only, and that is to take public health out of the Department of Community Health and make it a standalone state agency. What problem are we attempting to fix with House Bill 214? First, a little history in terms of how healthcare has been delivered and structured in this state for quite some time. Back in the 70s, then Governor Carter created Department of Human Resources under the notion that if you put a lot of different agencies with different missions all in one big pot, somehow or other it would work better. And of course, I think the evidence over time has been pretty persuasive that that's an ineffective way to do things. Particularly those of you who've been around here a while, that department became so big and so unwieldy and so unmanageable that, frankly, nobody could even manage the department. They had, I recall, at one time, a loose-leaf notebook explaining what all they did. It was over 200 pages explaining about all the various departments in that particular agency. As a result, a lot of things happened, but the bottom line is things were just not managed efficiently. This General Assembly and Governor Perdue last year, in recognition of the fact that that department had become unmanageable, had a reorg of that department and created a new Department of Behavioral Health and Developmental Disabilities, pulled that out, a new Department of Human Services, and they moved Public Health to the Department of Community Health. That was a major step in the right direction, in my view. What this does is completes that reorg if you pass this bill, and public health then will be removed from the Department of Community Health. Department of Community Health and the Department of Public Health have two different missions entirely. Department of Community Health is primarily an accounts payable department. They pay for services rendered by others, and that's not the mission of the Department of Public Health. So that's what the bill does. I have had discussions personally with our new governor. He is enthusiastically supportive of this concept of moving it out and making it a standalone agency. The notion that it be part of some big umbrella organization has just plain not worked. And in the meantime, for over 30 years, as the Department of Public Health changed division directors, and I don't want this to be I don't mean it to be a criticism of any particular person who had that job, but the mission and the direction and the vision in that department changed with whoever the director was. You'd go in this direction for 3, 4, 5 years, and this direction 4, 5 years, so forth. In short, it just got plain lost in the shuffle. Monies that were supposed to go to behavioral health wound up someplace else, and public health someplace else, and all of that sort of thing. So the bottom line is that if you believe that a smaller agency that is laser focused on what they're doing is the way to go, that's what this bill is all about. In short, I would compare this to the Department of Corrections. When you say Department of Corrections, you know exactly what they do. And what we want the Department of Corrections to do is be sure the bad guys are locked up all day, every day. And what this does is provides, from a structural standpoint, public health as an agency that will have cabinet-level status, if you will report directly to the governor. The vision and direction of that agency will be set by the governor. And I think that the outcomes are going to be vastly different. In short, and again, this is not a criticism of anybody, but in short, public health in this state is in a mess. And this, hopefully, this structural change will help that situation. There's a public health commission that met a number of times last year that was their requirements to do that was part of the reorg that we did last year, and held extensive meetings studying how the structure of public health should be organized. And the unanimous recommendation of the commission is that the Division of Public Health become an independent cabinet-level agency the Georgia Department of Public Health, with a commissioner reporting directly to the governor and acting by statute as the state's chief health officer. In terms of, some people might have a knee-jerk thing and say, well, you know what, here you are creating a new agency, going to cost the state more money. I again refer to you how we did that last year in the reorg of all these other agencies. And it was done at about the same time of year. That is to say, the governor's budget recommendations had already been made public, and the money that the governor had put in his budget for these various agencies was simply pulled out and followed that agency. It was revenue neutral, and that's what this proposes. You have, or should have, I think, in your packet, a couple of things that illustrate that, and one is the current suggested budget by Governor Deal. Now, that's not to say it's going to pass exactly the way it is, but assuming that it did, or whatever version of the total budget passes, and you can see this $192 million, state dollars, $659 million in total dollars. That money, if this bill is passed, this money simply goes to the new Department of Public Health, pure and simple. In terms of how much it's going to grow or not grow down the road, this General Assembly controls that. This General Assembly, along with the governor, appropriates money to all of these agencies. So I submit to you that it will be revenue neutral. I submit to you that for the same dollar amount, we'll have a whole lot better outcomes. And another sheet that you have shows, and again, this is straight from the budget document, but it also shows the different agencies of state government ranked by size. And that chart shows you that public health will be the 13th largest state agency in state government if you approve this bill. Madam Chairman, again, the bill is designed to do one thing and one thing only, and that is take it out of the umbrella agency of Department of DCH and create a standalone public health department. I will briefly, Madam Chairman, go through what's in the bill, and then, with your permission, I ask legal counsel to come down and assist me with the technical things. This is a long bill. It's very technical, but all it does is basically renames things and pulls things out of where they are and put them in another place. That's what it does. But this chart here kind of explains the things that this bill does. One, it establishes the Board of Public Health, and that's on lines 15 through 37 of the bill. It creates the Department of Public Health, transfers the division into a new agency. That's on lines 38 to 42. It establishes the Commissioner of Public Health, and that's on lines 43 through 47. And transfers, number 4, transfers powers to the Department of Public Health. The fifth thing it does is revises the state health officer requirements, and also addresses, from a legal standpoint, overlap areas where both DCH and public health should be referenced or included. The substitute that you have makes only, as I can make it out, only one substantive change, and that was done at the request of the governor. and that's on page 15, lines 496 through 499. The original bill had it that the public health commissioner had to be a physician, and the governor requested, and we changed it when brought forth this sub, that the commissioner of public health could or could not be a physician based upon the call of the governor. Is the bottom line. That's the substantive change that is made in the sub versus the bill as introduced. Madam Chair, again, with your permission, I'll ask legal counsel to assist me with some of the technical parts of this thing, but that's what it does.
Mr. Chairman, are you ready to take questions?
Yes, ma'am.
Okay. Questions for the chairman? Okay. Okay, Representative Reinders.
Thank you, Madam Chair, and thank you, Chairman Chanel, for this piece of legislation. As you know, we've talked about this before. I think it's long overdue. I do have some questions in regards to some of the information I'm reading in page 7. As you know, Chairman Chanel, many of our local boards of health have well-intended, well-meaning, everyday citizens on their local boards. I think it's a good question or a fair question about how active are they actually involved in the day-to-day operations of the local public health office. And some of this language, like the department shall establish a uniform method for obtaining conviction data, can they share that with Joe Q citizens sitting on their local board?
Jim Rons, what line are you referring to?
Well, it's throughout. The department shall establish a uniform method of obtaining conviction. That's on line 208. It's repeated again on 234. There's a line earlier that I was reading that said it's contractors that the department may. And I guess to shuck it down to the cob, as we like to say in South Georgia, I don't mind us doing fingerprints, background checks. We need to have good, solid citizens there. But I wouldn't want, unless it's tight in language, I wouldn't want that to go to just a well-meaning board member. Can you give me that assurance that that kind of information won't be available to them?
I'm going to defer to counsel.
I'm not sure as far as practically speaking. I mean, if they would need that information to make employment decisions, the board members may get that. But just kind of to put it in context, this code section is identical to the code sections for the Department of Community Health, Department of Human Services, and the Behavioral Health Department. So it's standard language across those agencies. It's basically to help them make employment decisions. And it would be confidential. It would not be public. But as far as what individuals actually see that, it would be who is making the employment decisions.
May I continue, Madam Chair? Thank you for that answer. The fees that would be, again, the wording is shall, let me find it, establish a uniform method of obtaining conviction data and the fingerprint fees. Is that something that the department would pick up the expense of, or is that something that if at the local level they wanted to hire someone, that the local Department of Public Health would have to pick up?
I think that's typically at the cost of the applicant, and I'm not sure if it's stated in here explicitly or if that's in their regulations, but I think typically that's the manner that it happens.
Would the wording of giving the uniform method of obtaining, could that potentially usurp the applicant picking up those costs?
Can you tell me what line you're looking at?
208. Shall establish a uniform method of obtaining?
I think that's basically just the procedure. They're going to say, where they go to get the fingerprints, how much it's going to cost.
But could they say, and it will be picked up by the local? I mean, since we're giving them that broad, that's my point. I don't want my locals to have to pick up that kind of cost.
Possibly. It may be covered in here. This is just duplicate language.
Okay.
I mean, we can add that, but I would prefer if I could have a chance.
I don't mind the applicant picking up the cost. I just wouldn't want my local board to have to pick it up.
Right.
Thank you, Madam Chair.
Representative Byrd.
Yes, thank you very much. Just could you explain to me what exactly is not being done right now under DCH that we would have to do another department?
Asking me that?
I'm sorry, the question is what?
The question, what specifically is not being done by DCH that we need to break out and have another department of public health? I mean, could you explain? Is DCH not doing their job for public health that we now need to make another department?
I think that would be a correct statement. I think, again, it's the missions of the two of them are very different, just like it was under the human resources. There was not direction, there was not vision. People didn't know exactly what they're supposed to do. Again, DCH is primarily in the accounts payable business. That they have an expertise in paying folks. They don't have an expertise in managing public health, which is a whole different agency. The whole idea, again, is to provide focus to that department and the leadership, so that they can have good outcomes. And I mean, there's a whole long list of bad outcomes right now in terms of how that is being run. And again, it has to do with management and vision, and what this does is puts that squarely under the governor's direction. And their concerns will be directly heard in that setup, that management setup, in my opinion. And again, it has to do with having a laser focus on what you're doing, and they've not had that in the past. And everybody, not everybody, but a consensus among a lot of people is, as a result of that, there is no specified direction that department is going in, and the outcomes are not good.
May I have a follow-up, please? Yes. And when you're talking about, you said that this would remain revenue neutral. So that means whatever money that we are giving to public health now under DCH, the monies would remain exactly the same and there would be no additional monies added to this new department?
That's correct.
And last question, please. On page 5, line 136. So we're creating a Department of Public Health, and now under Public Health we are going to then add a new Department of Office of Women's Health. Would you explain?
No, ma'am.
Okay.
All of that is current.
Current.
It's just making clear where it goes. In other words, it's not going to stay in DCH. It's going to public health.
Thank you.
You're welcome.
Other questions for Chairman Chanel? Okay. Representative Henson.
This isn't a question. I just want to say thank you, Chairman Chanel. I mean, this bill is long overdue, and I just really appreciate you doing this. Thank you.
Thank you for those kind words.
Representative Henson. Representative Kidd.
Mr. Chairman, Madam Chairman, thank you very much. My neighbor and friend, Chairman Chanel, obviously I remember working with the old Department of Public Health, probably in this room, but figured a little bit different years ago, back in the 70s and so forth. And it is way overdue in lots of areas. I apologize by asking a couple of questions I probably should know the answer to or should have talked to you about a little bit earlier. Section 8, I think it's page 20. Do you mind if I go through a couple of questions like?
No, sir. That's why I'm here.
Line 670. Now, I know we're transferring a bunch of stuff from the Department of Community Health over to the new Department of Public Health, and I have talked with several of the public health directors who, for the last number of years, are very much in support of something like this. Now we're tying in the Department of Behavioral Health through here, too. Is this part of the DOJ settlement that will be shifted over to the Department of Public Health now?
That language is in current code, and it's currently in the Department of Community Health statutes. That's going to be unchanged. The only reason it's there is for correct that cross-reference.
Well, I realize that, but I didn't know if it, because now you're talking about the three agencies, that's what part of that was.
No, public health still won't have anything to do with that.
Okay, also on page 20, you make reference to, here again, all existing law transferred over. So you're making payments to hospitals and so forth. I wrote down what line it was. On page 20, that's where you're, I guess you're using some of the funds there through the department to make payments to the hospitals that offset some of their costs for what they do in the area of public health, like I assume like you're doing now, or supposed to be doing now.
Representative Kidd, again, this bill makes no attempt to change policy in terms of what either department is doing. I mean, maybe it needs to do that, but that'd be a bill for another day and another time. What this simply attempts to do, as I said, is simply move this out of DCH and into a standalone agency. All these other things are what they're already doing. And
let me ask you one last question,
sure.
and anything else I got to talk to you privately later on. On page 18, you got the newly underlined stuff starting line 592 going on down. Seems to me like there's some dates that ought to be changed in there. Position of the Director of the Division of Public Health shall be abolished effective July 1st, 2011. And you're making reference to the Department of Community Health as 2009. I'm sure it's all proper, but you just read kind of funny when you're changing the dates. And
well, as it relates to the June 30th, 2009, that's on line 595, 96, and 97. As you know, that's actually when the reorg took place and when public health went into DCH. And what that sentence attempts to address is to make it clear that, and again, key date, June 30th. July 1 is when it changed. And June 30th, what this sentence, and correct me if I'm wrong, Counsel, but what that attempts to do is make it clear that we're not taking anything away from DCH as it was before public health came over.
One last question, and I promise it'll be the last one. You've got X number of employees that will be with the Department of Public Health.
Yes,
now.
Sir.
And it seems like the Department of Public Health, separately or in conjunction with all the other departments, will be negotiating the health insurance plans for that department. They're doing it separately in conjunction with the Board of Regents. I think that's the top of page 9. I assume it's where it's done now. Top of page 19. I'm uneducated. It might be the way the Department of Community Health does it now. I don't know.
Again, this does not attempt to change that, but they are under, say, their benefit plan now.
I just didn't realize that they were negotiating with the Board of Regents to do it. Thank you, Mr. Chairman. Thank you, Madam Chairman.
Okay, seeing no further questions, we do have some people that want to speak in the bill. Mr. Williams, who was, maybe Dr. Williams, who's Dean of the College of Public Health at UGA. There are other schools besides UGA. Dr. Williams, I'm being funny. Because people picked on me all day for wearing another school's colors. Yeah, right, I know. And so you served as the chairman of the Public Health Commission?
Yes. Madam Chairman and members of the committee, I'd like to thank you for the opportunity to address this body. I'm Dr. Philip Williams, Dean of the College of Public Health at the University of Georgia. Last summer, I had the honor to chair the state's Public Health Commission, jointly appointed by the governor and state legislature. It is in this role that I'm here to share our recommendations. Our commission worked from July through December. Members included 9 Georgians with varying backgrounds, experiences, and viewpoints. Both the public and the private sector were represented. Some possessed direct experience in public health, and others came from a more business-oriented background. Our charge was to examine whether the state would be best served by keeping the Division of Public Health within the Department of Community Health, or if a change would be beneficial. We evaluated many possibilities, including the status quo. We also evaluated moving the division under the oversight of another state department, perhaps operating as an attached agency within the Department of Community Health. Lastly, we examined whether it should be its own independent, standalone state-level department. To identify the best practices for Georgia to pursue, the Commission held 7 meetings last year and collected expert testimony from a cross-section of stakeholders, including public health professionals, current or past commissioners of DHR, DCH, and the Department of Behavioral Health and Developmental Disabilities, academics, and several elected officials. 3 members of the state legislature testified: Representative Mickey Chanel, Representative Donna Shelvin, and Senator Renee Unterman. Additionally, members of the Commission received feedback from the public during our October 18th meeting, as well as an email throughout the engagement. The Commission took its charge very seriously, weighing the pros and cons of each suggested option and carefully evaluating how each model of governance would work. It is a unanimous recommendation of the Commission that the Division of Public Health be moved out of the Department of Community Health and set up as an independent department with a commissioner that serves as the state health officer, reporting directly to the governor. The Commission feels very strongly that an independent Department of Public Health is the best option to improve the overall long-term health of the citizens of Georgia and lift us from the bottom of various health rankings. Public health impacts every Georgian, as well as the tourists who visit our mountains and beaches, eat at our restaurants, and travel along the highways and roads. Since 9/11, our public health responsibilities have also included 24/7 emergency preparedness and disaster response planning, from hurricanes to terrorism. This level of responsibility justifies the full-time attention of a commissioner who reports directly to the governor and interfaces directly with you, our state legislators, about the needs and capabilities of the public health system. This commissioner would also, and perhaps most importantly, interface directly with our citizens. Just as importantly, our committee believes that this department can be established and effective without additional resource allocations in the near term, and will build a platform for even better health in Georgia when additional public and private support becomes available. As a founding dean of the College of Public Health at the University of Georgia, I'm proud of the quality of the education offered by our institution, the dedicated care, service, and leadership our graduates provide to the citizens of Georgia and around the world. Along with my colleagues at the other public health colleges and programs in Georgia, we have thousands of students preparing for public health careers in both the public and private sector. Our students stand ready to prepare Georgia for a healthy future. Our graduates are already making this happen. By choosing to establish an independent Department of Public Health, you will be fostering an environment that allows our public health workers to more rapidly, more efficiently, and more effectively improve the health of millions of Georgians. Thank you.
Thank you very much. Okay, Rebecca Greener? Can't get it out. Sorry, Rebecca.
No, I'm sorry, that was me. His phone just rang.
Then you don't get to speak.
No, I'll be quick. Rebecca Greener with the Medical Association of Georgia. We do support this bill. I want to thank Chairman Chanel for bringing this once again, and for all of his work over the past years on this piece of legislation.
Okay.
Thank you.
Thank you. Scott Maxwell.
Madam Chair, members of the committee, I'm Scott Maxwell, and I represent the Georgia Public Health Association. And in the interest of your time and not repeating what's been said, I just want you to know that the association fully endorses and supports the bill, and thanks Chairman Chanel for bringing it. Thank you.
Thank you. That's all the people that can speak. Anyone else want to speak on the bill? Okay. All right. Is somebody else coming to speak on the bill? Okay. If you identify yourself.
I'm Ann Mintz, and I represent United Way Metropolitan Atlanta and all the United Ways in Georgia, United Ways of Georgia Incorporated, all of whom strongly endorse Chairman Chanel's bill. This is very long overdue, and I guess the best way to explain it is the public health system is kind of like one of those programs that's operating in the background of your computer, and most times you don't know it's there, but when it's not there and your computer crashes, then you're in trouble, and that's probably where we are today.
Thank you. Okay, what is the head of the committee? Okay. Representative? Okay, we got it. You can second.
Okay. Madam Chair, it's with pleasure that I recommend that we make a motion to pass LC 334071S.
Okay, substitute to House Bill 240. Okay, we have a motion and a second.
Madam Chair, I would love to second this motion and let you know that there are a lot of elder statesmen, politicians who are in their grave now that are dancing a jig because this is getting ready to pass.
Okay.
Thank you very much.
Okay. With that, is there any other discussion? I would like to offer an amendment to the bill. Chairman Chanel, you know there is a program that is very near and dear to our heart, especially to yours. And I feel like I had a little bit to do with it because it was one of the first bills, if not the first, that passed out of this committee. It's our Volunteers in Medicine Health Share Act. And it is in DCH, and it is a small program that could easily get lost, that fits in public health, because public health looks after people and has been traditionally for people who don't have access to usually insurance and health care and the things that are offered by public health. And that is what your program is all about, is helping people who don't have insurance and access to health care get that. So those codes were in the first part of this bill, the first original, and they somehow or other got left out. So I would like to offer an amendment that they be added back in, if that is okay with you.
I would enthusiastically support that amendment.
Thank you. I feel very strongly about that one, and I would like Betsy to read where they would go.
All right, so this is going to go on page 45. I'll get there. This is the laundry list of code sections where the term Department of Community Health has changed to Department of Public Health, and it will go between lines 1556 and 1557. We're apparently missing a 39 there anyway, so we're going to add a 39 that says code section 31A-192 relating to definitions relative to the Health Share Volunteers in Medicine Act, and then after that is going to be a 39.1. It says code section 31A-193 relating to the establishment of a program to provide healthcare services to low-income recipients.
Are there any questions on the amendment? Mhm.
Sorry I was late. I don't know another meeting.
Fullerton.
One question.
What number?
16. You got it.
Got it. I got it.
Sorry, I was at another meeting, and I appreciate being able to talk. The members of the commission that will be volunteers, essentially of the Department of Public Health, their backgrounds will vary. They will not be all physicians. Or
Wait a minute. We've got an amendment. This is not related to it, and then we'll go back to that
okay,
before we pass.
that sounds good. Thanks.
Okay. We have an amendment. Do I hear a motion on the amendment? So we have a motion to move and a second. Second. And everybody in the favor of amendment as read by Betsy to add back the Health and Volunteers in Medicine Share Act, say aye. Aye. Anyone opposed, no. Okay, the ayes have it. The amendment passes. Is now, Representative Fullerton. We're back on to any more discussion on the bill.
Apologize.
That's all right.
Representative Chanel, our chairman, these will not be all physicians or all one kind of background of person. It will be varied as the DCH board is now.
Are you referring to Volunteers in Medicine now?
No.
No.
To the full Department of Public Health.
And again, I'm sorry, what is your question?
That the people who will serve on the board, I think it was 9 people.
Yes, ma'am.
They will be from varied backgrounds.
They will be appointed by the governor, and in his judgment, whoever. I don't think their backgrounds are enumerated. I don't think, and they serve at the pleasure of the governor.
But we would not be going back to what we did in the early 70s of there being all physicians.
No.
Okay. Thank you.
Okay. Another question from Representative Reinders.
Thank you, Madam Chair, and I'm going to defer to my good friend who's done such a great job on this bill as whether he thinks it's appropriate or not, or at least something he may want to shop when we move it across the hall. But my inclination is, just to make sure that we show legislative intent, is following line 257, the friendly, which deals with that issue that I brought up earlier, Chairman Chanel, in regards to criminal background data information and who may or may not get that information. There's something that the wording that I'm coming up with is something to the effect of nothing in this code section shall be interpreted as allowing personal criminal history, including arrest and conviction data, to be released to any individual, including but not limited to the local board members who are not directly involved in the hiring process.
Jim Rums, I don't have a problem with it unless I'd like to ask council to do something unintended.
Yeah, and I don't want to do that. I don't.
Oh, you're not offering.
No, I don't want to. I don't want any unintended consequences. So thank you for the question.
I think that's fine. I think it's already covered. He's trying to just make sure that the people that are doing this decision with all of the, I think it's covered somewhat already in subsection D on the previous page. So you're trying to.
As a legislator, let me answer that, Ms. Betsy. And I know one thing doesn't paint it, but we have to be careful. I actually received a call one time from someone that some information was released when it shouldn't, just kind of fell through the cracks. And when you're sitting with good volunteers on some local board sometimes, we don't need to, they couldn't hire if they wanted to, but they don't need to get that information. And there's just a part of me that says, you know what, let's make sure that we put that in writing. And again, if you just want to talk about it afterwards, that's fine too. I don't.
No, sir. I'd rather deal with it right now.
Okay. 7 page line. I'm sorry. Yes, that's fine. Yes, ma'am, and I'll ask that legislative council do a great job of cleaning it up for me. But nevertheless, you'll get. That's it. That's exactly right. And it's nothing in this code section shall be interpreted as allowing personal criminal history, including arrest and conviction data, to be released to any individual, including but not limited to local board members who are not involved in the direct hiring process. Yes, you may. I kind of expect that.
No discussion. Do I have a motion on the amendment? So move. I have that we move on the motion on the amendment. I have a second. Everyone in favor of the Betsy Reinders amendment, say aye. Aye. Anyone opposed? No. Okay. The ayes have it. All right. Any others? Okay. Hearing none. We have a motion and second on the substitute to House Bill 214. Everyone in favor say aye. Aye. And that would be as amended, of course. And anyone opposed say no. Okay, so the substitute to House Bill 214 goes out as amended as a committee sub. Thank you very much. Thank you, Representative
Madam
Chanel.
Chairman and members of the committee.
So, thank you for all the hard work on this. Okay, no, I thought we've only got one more. I think I'll just let them stay for a second. We're running pretty close. Okay, who's we got? We've got, all right. Okay, what's the number? Where's your agenda? Right there. Okay, Representative Watson, House Bill 147. Have I heard about this bill before? I think Representative Watson has broken my record. I'm not sure that our record, because I'm not sure this committee has ever had a bill returned from rules. I'm picking on you, Representative Watson, because you're a good sport.
I appreciate that. Thank you very much, Madam Chairman. And as I always say to many of my patients, there is a first for everything. That's right. Thank you. I am here to bring to you the substitute for House Bill 147. This is LC 36185S, and it is an amendment to the Patient Right to Know Act of 2001. And this adds on whether or not a physician is carrying medical malpractice insurance or not, and allows the patient to ask the physician that question. The next page refers to the data collection that the Composite State Board of Medical Examiners will collect and will report back to us. That will be available. This refers to basically the Patient Rights No Act of 2001, which was enacted 16 questions, and this will be an additional question that is added to that. The 16 questions include things like obviously the name, medical school, date, specialty, hospital privileges, practice settings, whether or not the physician participates in the Medicaid program, and any felonies or any pleads of nolo contendere, and also includes any malpractice settlements or judgments. This will add the question of whether or not the physician has malpractice. As you may know, the physicians, if you are a member of a hospital staff, the physician does have privileges there. Then you will have malpractice coverage. If you accept insurance, then by credentialing, you will also have malpractice coverage. This basically adds just one single question and is and then collects the data. That is the simple aspect of it.
Representative Watson, I think what we need to know, and thank you for going over the bill and reminding us what it does, because we have so many bills that come through, you can figure it out pretty easily. Why did they send it back from rules?
It is back for basically two reasons. The first reason, underneath the whether carrying any medical malpractice insurance, basically I was trying to be a little cute and added in the definition of retirement, in which the retirement definition was actually already done, and in the section that is already questioned, that is already included in the questionnaire. As I said before, there's 16 questions that the state is mandated by law in the Patient Rights No Act, and then there are about that many more questions that are asked and followed up on. And they do a good job of that, so that was superfluous and not necessarily needed. The next aspect was the Composite State Board of Medical Examiners had asked us to carry a portion of that bill having to do with the rules and regulations relating to fining physicians, and they wanted the ability wanted the discretion, since most of the fines or discretions that physicians were not doing was reporting their change in locations, and these were young physicians who were doing that. That, in delving into that deeper and consulting with the Attorney General and with Composite State Board of Medical Examiners, that basically got to be more than this author was willing to carry, and was beyond the scope of what I thought this bill should be.
Thank you. Okay, Representative Kidd.
Question for me. You're not asking them how much malpractice they have. Just yes or no, you got 100,000 or 3 million. It doesn't make any difference.
That's correct.
Or I see you guys here whether you're asking them if they're board certified. Obviously, a lot of practitioners who are not board certified. Line 39, page 2. You ask them what board are they certified. As you know, a lot of physicians aren't board certified, but they're medical doctors licensed by.
Yeah, that actually is already in the law. That's part of the data that we're collecting. That second page is already there. We're just asking them to report the data to us.
I guess because it's underlined. To me, is it underlined? To me, it looked like it was all new.
The whole section is new. The data collection is new, and that's what is included. I have here the code section of physician profile, and let's see.
Okay, Representative Watson.
Yes.
I think Betsy can answer that question for you.
I mean, that is a new code section, but it's requiring the information that they already collected under another code section is what the representative is saying.
Okay.
It's not, it doesn't appear in the bill, the whole bill. So they're already collecting that information about the board certification, but now it's saying that they have to aggregate that data and make a report available to the General Assembly of the government.
Well, I was just curious if the data is going to be used somewhere, and you've got X number of orthopedists. You might have 3,000 orthopedists, and 2,000 of them are board certified, and the others aren't board certified. You're really getting a report that there are 2,000 board certified orthopedists.
This is the physician profile that is obtained by logging on and obtaining that information that is already available. It is there. Each individual patient can log on and make an intelligent decision if they so desire before they see their physician or any time in that care, and see whether or not they carry malpractice or whether or not they accept Medicaid, Medicare, and so forth. And that was part of the data that was there.
No, wait a minute. No. 605. We have some people leaving. They're going to talk about another thing. So 605, room's right close to you. Okay. Any other questions? Okay. Oh, Representative Reiner.
Thank you. One more. I just want to make sure I'm going back from memory. What we've changed here is to the patient has the right to ask.
That's correct.
But going back to the Chokus Amendment, if I remember correctly, the physician is not obligated to tell the patient that he's looking after that he doesn't have it.
No, that's not correct.
That's not correct.
No.
He has to tell them now.
Yes, this was always in there.
Okay.
I got you confused, or me confused. The part of the Patient Right to Know Act includes asking the physician the charge and other questions. This adds in that the patient has the right to ask the physician that malpractice question, and they're required to answer that question, or have somebody in his office answer that question for them.
But it does not obligate the physician to tell, if he's not asked, that, oh, by the way, you need to know I don't have malpractice.
No, that was you're correct. That is the...
They still don't have to tell them. Okay, thank you.
That's correct. I'm sorry.
Okay. All right, we don't have any other... Okay. Okay, Representative Morgan.
Thank you, Madam Chair. Just a simple question. How would a patient know to ask that question?
Maybe sort of like the same question of how are you going to pay this bill? Where did you go to school? It's just sort of the general realm of questions that you would ask, and it may not be something that would occur to you, or you may not want to. If they want to log on and get that physician profile, that's there. If they're have hospital privileges or they accept insurance, then that's going to be there already. Most patients are not going to ask that question necessarily. It would be the patient who is interested in whether or not they want to know that information or not. Many people don't want to know that. I personally have never been asked that question.
Well, my guess is because people don't know what medical malpractice insurance is. They don't know what the impact of you having it or not having it has on their care. I mean, I've never asked my doctors, other than the ones that I like who went to Spelman, like what school you went to. So I guess I'm not understanding the purpose, and is it whether or not there is some public information campaign or something that's going to happen that makes the general public aware that they have the right to ask these questions, and that they should, and what the ramifications are of the answer.
And that's part of the data collection that we'll get. We'll get back from there whether or not this is an issue or not. This is part that was Law 2001, the Patient Right to Know Act, and it's available there through the Composite State Board of Medical Examiners. You can request it by email, you can request it by phone, you can request it in person, or you can just log on and get the information on every physician in the state of Georgia. And it's not just on malpractice. We're just adding that particular one issue.
Okay, Representative Morgan, I don't know if you were at the last meeting or not. We had an amendment that was offered that the physician would.
Absolutely, Madam Chair, and I did vote in favor of that amendment, which failed. But my issue is still the same along the lines with that amendment. You know, we're calling this the patient's right to know, but we voted down an amendment that will actually give the patient the direct right to know by signing a paper saying that this doctor has let me know that he does not have malpractice insurance. I don't understand that. We voted that down, but I thought that was a good idea. And I still think it's important. Your question was why a patient wouldn't think to ask. Well, I think most patients think that doctors have to have malpractice insurance, honestly. And And but I commend you because I've learned two things. One, if a doctor tells me he doesn't take insurance, that's a red flag for me from now on. I used to think, oh, he's so hot stuff, he don't need to take insurance. He takes only cash patients. Well, now that says to me, maybe he doesn't have any malpractice insurance. The other thing is that if a patient doesn't have privileges at certain hospitals, I used to think maybe he had a falling out with administration. Well, now I might think maybe he doesn't have malpractice insurance. So I commend you on those two, giving me two red flags that I need to look out for and tell my constituency to look out for. But I still think we would be remiss if we didn't put something in this bill that automatically, I understand from the last time that it's posted or something or not posted whether they have malpractice insurance.
No,
and looking online, I don't know if y'all know it, but a whole lot of people still don't use computers. And but I think if they had to sign something within that stack of paperwork that they have to sign initially that says, I am aware that this doctor does not carry malpractice insurance, I just think it would be in the best interest of all patients.
Yeah, the Patient Right to Know Act 2001, that information is there available in every physician's office waiting room. It is there, and again, it can be by telephone, it can be by verbal, it can be by letter. You don't necessarily have to log on.
Right, it's posted. So is birth control pills and Bible, free Bible inserts and all kind of stuff that's posted all around. But something that important should not get lost in the shuffle of everything else that's posted around a medical office.
I agree it's important.